Now, you've conducted a phase 2 study. It's a combination of an anti-VEGF, sunitinib, with chemotherapy in a group of patients with renal cell carcinoma. Now, tell me, first of all, which group of patients and why were you looking at a combination of a targeted therapy plus chemo?
Certainly. So the group of patients that we conducted this study in was in patients with sarcomatoid RCC or poor risk RCC. These are patients who historically have very clinically aggressive disease that doesn't respond well to standard therapies, standard VEGF therapies. And so it's certainly an unmet need in regards to the management for these patients.
How much of a response were they getting to single agents of things like gemcitabine and sunitinib, the components of your
So with gemcitabine, single agent gemcitabine was associated with response rates of about 10%. And VEGF targeted therapy was associated with response rates of around 19%.
Okay, so tell me about the study, please. What did you do?
So in the study, we actually took patients with either sarcomatoid or poor risk disease. There was no randomization. All patients were treated with gemcitabine at 100,000 milligrams on day 1 and day 8 of every 21-day cycle. And they received sunitinib at 37.5 milligrams daily, 2 weeks on, 1 week off. And they were followed for response. That was the primary objective of the study. And what we found was actually in patients with sarcomatoid disease, we had about 39 patients in that category. The response rate was 26%. And for patients with poor risk disease, the response rate was 24%.
So what are your conclusions from this?
So actually, this study, in addition with the phase 1 study that led to the standard doses to be used in this study, has led to a randomized phase 3 that's being put on by one of the cooperative groups, where patients are randomized, all patients receive sunitinib and then they're randomized to receive the gemcitabine. And so that should really be the definitive study to answer whether our findings actually are going to change standard practice.
Clearly, it is difficult to know what to do if you have a patient with the poor risk renal cancer. What's your guidance coming out of this? Obviously, you've not got all the answers yet, but what practical messages could you give to doctors?
I think for patients who have sarcomatoid RCC or clinically aggressive sided disease, and you really need tumor shrinkage, I think reaching for a chemotherapeutic agent such as gemcitabine and combining it with Sutent, like we have in the study, could offer objective responses that are really needed for those patients.
What about the actual choice of VEGF agent that you're using? Could you use a different one?
So in this study, we used sunitinib. It is conceivable that you could potentially use pazopanib, or conceivable that you could use a monoclonal antibody, but that's not what this study did, so I can't comment directly on that.
Okay, so to summarize the hope coming out of this at the moment, what would you say in a few words?
For patients with sarcomatoid or poor risk disease who have clinically aggressive disease, the combination of gemcitabine with sunitinib was tolerable and led to objective responses in those patients.